just to start off with the haymaker and the elephant in the room, let's talk about the infamous 2009 NEJM studies that are still off-quoted, less off-understood and perhaps read, but necessary to understand for how we are where we are now. And our understanding has changed with time, but we have to understand how this has impacted the field.
I mean, there is absolutely no question that the 2009 trials were a seminal moment, their publication at least, and when we found out about them from the journal right beforehand with an opportunity to comment. If I may, let me step back a little bit. Sure. So vertebroplasty started in France as a treatment that was specific for a hemangioma in the cervical spine. And a reluctant radiologist, with the encouragement of his surgeon, percutaneously placed cement. In France, this technique and this procedure developed from the 80s into the 90s, and then through a quirk of fate, neurointerventionalists were present for a presentation on augmentation, went back to their institution. As IR is often a place where people congregate to talk about hard cases. The story goes that an orthopedic surgeon had a compression fracture patient, a woman who had breast cancer, metastatic breast cancer. That's a fact that few people actually know, that the first person treated at UVA, to my understanding at least, because I wasn't there, was a breast cancer patient, and it went great. It took a couple of years for them to get about 30 patients, 48 fractures, and they published the article in the AJNR. Lee Jensen was the first author, and that really described the technical approach to vertebroplasty, and in describing their experience, this became very important in the community. Pioneers like Dr. Kieran Murphy, who I understand may also be speaking to BackTable at some point today, actually organized meetings around this new technique. I remember attending those meetings with people that I long knew, long admired, continue to be friends with today. First and second were in Cozy, Utah. And I would say there was palpable excitement because you took patients that previously were relegated to bed rest, opioids. Hey, it's a benign fracture in an older patient. There's nothing to do, nothing you want to do. They'll get better on their own. You know, these fractures get better. Boy, the world changed with a little cement, because as you put in that little cement, people who were immobilized started to be able to walk. People who were in the hospital for 2 weeks previously, there was CMS data that suggested patients were on average in the hospital for 10 to 14 days. We're going home the next day. In the beginning, we didn't know. We were putting tantalum in the cement. We were sterilizing barium. We were doing all kinds of stuff. I mean, this is before kits existed, so to speak, stealing needles from here, grabbing cement from there. And I would say the growth was considered in that at that time we weren't teaching it to everybody because we thought this could be quite dangerous, taking an 85-year-old person, laying them on their belly, injecting cement. I would say that it was an incredibly exciting time because it felt like magic that you could change people's lives. I mean, vulnerable, older people with osteoporotic fractures overnight. To give you a sense, though, I used to transfer my patients prone to prone because I didn't know how long it would take to set up the cement. Obviously, our practice evolved. We stopped including injectable tobramycin. And there was a monumental growth of the procedure, especially as we realized that it was safer, and especially as people realized not everybody could be treated at UVA or Leahy Clinic. This is a disease of the community, and you don't want to say to a elderly in-pain person, travel 2 hours to get your procedure, travel 2 hours back. So I think a lot of us, people who are here at ASSR, had the belief that we're not specialty specific, we're not thinking this has to be done in academic centers. As we learned this was safe, our goal was to disseminate knowledge of how to do this procedure to the community. In that period, Dr. Riley, I think, working with Karen Talmadge and other folks, developed a parallel procedure beyond injecting cement directly through a needle, where you'd use some principles of angioplasty and some principles of AO fracture that were prevalent at the time, in thinking about reducing the fracture using balloons and then injecting cement. The company was called Kyphon, and that's where the term kyphoplasty came from. Without getting too much into the history, though, the earliest people trained in that procedure were radiologists. For most of us, we actually stuck with vertebroplasty. And again, I think it's probably not important why. You probably wouldn't know this. In fact, this may be the most surprising thing that I'll share with you today. One of my least known articles is one that I published with Dave Calmes and Jerry Jarvik. I forget what it was called, but the simplicity of doing a randomized controlled trial in vertebroplasty. I called for such a trial. I believed in doing that kind of trial. And I would say that I was pleased to see that David, Jerry, other investigators were trying to get their arms around proving that vertebroplasty worked better than sham, which, to be fair, was obvious to me, right? I mean, you took people, they were laying in bed, they couldn't move. At that time, opioids weren't being pushed quite as heavily as they would later, but you were giving elderly people opioids with this crazy notion that opioids were fine in the elderly, which when I argued against got me kind of hostily attacked by people who were supporting opioid use. And what I would say is that there was a lot of infighting between vertebroplasty practitioners and kyphoplasty practitioners. That's pretty destructive, pretty unfortunate, when we should have been focusing on the millions of people that aren't being treated because they don't have these treatments available. I will tell you that Mass General tried to become an invest site. I was a believer in doing this trial. The IRB did not feel we should proceed. They felt that it seemed like vertebroplasty was working, so putting people at risk with sedation for what was called sham, but we could probably better term controlled intervention, was not a good idea. And so we were the only site to not participate. So INVEST was going on internationally. And then there was a small trial run by a woman named Dr. Rochelle Bookbinder in Australia. Now, it's important to recognize there were many papers already describing the excellent benefits of vertebroplasty and kyphoplasty, and they included papers that compared against best medical management. So the real-world comparator, vertebroplasty, kyphoplasty, Vertos 2 for vertebroplasty came out, I want to say in 2010. Kyphoplasty, the free trial, came out in 2008. The trials were demonstrating how, against what you would do in the real world, they were incredibly effective in every parameter. So in 2009, these studies come out. And as I mentioned, it was a very tumultuous time because I'm sure in keeping with the rules of the journal, the societies were contacted for KOL commentators on these trials in the immediate pre-release of these papers. So the societies and the KOLs that believe in this and the patient groups that believe in it were caught a little off guard because papers like the New York Times, the Boston Globe, I'm sure the San Diego Chronicle or whatever paper of note was here in San Diego at that time, all kinds of papers ran articles about how vertebroplasty was no better than a sugar pill. Really, I mean, crazy. I remember it like it was yesterday, and yesterday wasn't such a great day. But, you're talking about two tiny trials, and I think they were well-intentioned. The goal, at least one I know for INVEST, was to prove that vertebroplasty worked. And Dave Calmes makes a very famous statement from the podium more than once. There was one major edit that the New England Journal wanted. The authors wrote vertebroplasty worked, but sham worked as well. And I think that started getting into an incredibly important education for the community. Naturally, the proponents of the procedure who were shocked could not believe that vertebroplasty wasn't obviously better than sham. And what they did was to pick apart the studies. And that's relatively easy to do, right? Like a Monday morning quarterback. This was bad about the study. This was bad about the study. I think the doctors who were putting together the study, well-intentioned doctors, they perhaps didn't understand things like placebo and nocebo, things we've certainly learned a lot about since the procedure was done. Can't bottle placebo effect. You can't bottle nocebo effect, meaning I can't do a procedure on your neighbor and say, okay, I'm doing a sham procedure and hope you're better, meaning placebo and nocebo are real. You just have a really hard time utilizing them other than in a trial situation. In addition, in the INVEST trial, I mean, the weaknesses of the trial are well known, but to David's point, nobody ever criticizes my other studies. How come you guys only focus so hard on INVEST? And I have an answer for that. The one, again, I gave from the podium to him. The trial compared an active therapy, which was the periosteal injection of lidocaine or bupivacaine, I think was a choice, versus the procedure on what I think was the mistaken notion that shouldn't have any impact. Now, a real test of sham would have been to put a needle and not inject cement. I think most people would have thought that unethical, and I think they were trying to find a compromise. I think a better compromise would have been what was found subsequently in the vapor trial when they just injected a little subcutaneous lidocaine versus lidocaine at the site, which actually later became a treatment paradigm that was proposed by folks out of England. In 2009, when this was simultaneously published with the Bookbinder study, and I believe for all the criticisms of the INVEST trial, the Bookbinder trial could be more criticized. It was 70-something patients, and I think it was methodologically quite flawed. I don't think it would have been published in the New England Journal of Medicine had it not been a companion study to the INVEST trial, which I think was a better. But those two studies coming out at the same time had an incredible chilling effect on augmentation. That came up in some subsequent work that we did, but doctors who were familiar with the positive impacts of vertebroplasty stopped making referrals, even in a place like Mass General, where we had been offering that service to vulnerable patients for a long time. And I can't tell you how long it went for, but I feel like we may have gone weeks or maybe months without having any real referrals. Of course, since those patients didn't really have an opportunity to get better, those referrals came later with more disturbed vertebrae. And fortunately, after that shock, there has been an opportunity to revisit what trials might look like. And we've seen positive trials that have come out. I think you meant that to be a relatively short question. It had a bit of a long...
That was kind of how I intended for it to go. No, that was an excellent overview.